Welcome everybody to this international session of the 2023 International Conference on Stigma. My name is Chris Duncombe. I'm the Chief Medical Officer at the International Association of Providers of AIDS Care. I'll be your moderator for today's session. We're going to start with the speakers while we try to fix the issue, and we have two presentations. These presentations are reducing stigma and promoting mental health for sexual and gender minorities in Nigeria and in the US. And the second presentation is Stigma, Social Support, Perceived Stress and Satisfaction with Life amongst people living with HIV in Oman. So our first speaker is Julie Pulowitz, who is a senior socio-behavioral scientist at the Population Council, providing leadership for a global portfolio of HIV and gender-based violence research with a focus on gender inequalities, stigma, and implementation science, as well as appointed faculty at the George Washington School of Public Health. She is part of a scientific leadership team of the HIV Prevention Trials Network, a co-chair of USAID's Male Engagement Task Force, and co-chair of the Global Scientific Interest Group at the DC Center for AIDS Research. Among her contributions, she has developed widely used tools that measure gender norms and attitudes, couple power dynamics, and the PLHIV resiliency scale. Dr. Pulowitz received her master's and doctoral degrees from Harvard School of Public Health and is a highly cited author with work that's been profiled in The Lancet and the New York Times. Julie, over to you. If you could share your screen, that'd be great. Thank you.
Thanks very much, and I will share my screen.
Just while Julie's doing this, please feel free to put any questions or comments in the chat, and we'll have some time for Q&A at the end of the two talks, and then hopefully if we can run the video then. Julie, that's perfect. Yeah, that's perfect. Thank you.
Terrific. Thanks. Good morning, colleagues. Good morning and good afternoon to those of you who are joining from other locations around the world to this virtual portion of the conference. It's great to join you, and I thank the organizers for inviting me to present today. I am based at the Population Council and George Washington University. My name is Julie Pulowitz, and today I will be speaking about reducing stigma and promoting mental health for sexual and gender minorities in Nigeria, and then a bit about a new project in the DC area. Let's see if my slides move. Yes, they do. I'd like to start with acknowledging my collaborators, of which there are many, and partners. First, at the Population Council, both in Washington, D.C. and in Nigeria. The Population Council is a 70-year-old organization that focuses on evidence generation on health and development issues to strengthen programs and improve policy. And so I work particularly in the areas of sexual and reproductive health and rights, including HIV, and I would also highlight our collaborators and partners, the Center for Population Health Initiatives, and TEARS, the Initiative for Equal Rights based in Nigeria, and our funding support from the Elton John AIDS Foundation. And of course, various stakeholders that have been supportive and actively involved in this work, including the State Agency for Control of AIDS, the Ministries of Health, and the Network of People Living with HIV. We come to this work, the contextual perspective is that there are many different types of stigma that we're talking about here at the conference. And we're going to be focusing particularly on internalized stigma and intersectional stigmas with this work I'm going to talk about. So we know that the effects of stigma are compounded when negative assumptions and stereotypes are internalized, which we also call self-stigma. And in fact, there was a session on internalized stigma yesterday, a very interesting session that I joined. so it's a theme here at the conference. We're also looking at intersectional stigmas. In this case, looking at HIV stigma and homophobia, stigma related to being a member of a sexual or gender minority, which mutually shape experiences of sexual and gender minorities who are both at risk of or living with HIV, and as such should be explicitly taken into account. We also know that stigma, internalized stigma in particular, is associated with a number of health outcomes, mental health and physical health, including reduced self-esteem, depression, and limited health services use, such as HIV testing and PrEP. And then finally, resiliency, or what has been defined as the positive adaptation when confronted with significant adversity like stigma, is associated with less internalized stigma. So, in other words, folks who report less internalized stigma are more likely to report being resilient. At the Population Council, we've been working in Nigeria for some years with the community of sexual and gender minorities, offering services and generating evidence on how best to do that related to HIV prevention, care, treatment, and support. And we've been largely working in the healthcare setting and focusing on, for example, reducing stigma in the healthcare setting, supporting sensitization of providers, and other activities like that. And there was a call from the community to also look at internalized stigma and mental health. When we turned to think about developing programming focused on reducing internalized stigma, we saw that there are in fact few evidence-based or gold standard interventions that address internalized and intersectional stigma for sexual and gender minorities. And that could be for people who are at risk of or living with HIV. And there were none that were developed specifically for African settings. So we went about to develop and test an intervention that we'll be talking about today. I'll spend a little bit of time talking about the intervention itself. We adapted what's, in essence, a mental health curriculum for sexual and gender minority youth from Canada. And then we combined that with several African-based HIV and stigma curricula to create something that would be useful in the Nigerian setting. And it draws upon, in essence, cognitive behavioral therapy. So cognitive behavioral therapy is a well-established and tested strategy for supporting mental health. What's novel about this project is that it is a group-based cognitive behavioral therapy. That's a promising approach that's been used in several places, where the goal is to bring together a group to support one another, support resiliency across the group, and also to make it possible to reach larger numbers of people, as opposed to just a one-on-one with a psychologist in a context where there are a very limited number of psychologists. I would also highlight that it uses an affirmative approach, so kind of identity affirming CBT approach. This program was facilitated by community-based health extension workers who were trained by psychologists. So again, this made it possible to reach larger numbers of people and bring in members of the community as facilitators. I would also highlight it's an HIV status neutral intervention, meaning people who are at risk of HIV as well as people who are living with HIV. Everyone could join the program. We were really focused on mental health and stigma reduction. Although we did have separate groups for men who have sex with men and transgender women, based on feedback from the community, that was important group to have separately. We have multiple safety measures in place. In this context, in Nigeria, same-sex behavior is illegal, so it's very important to have a safe space with a venue, and we also had psychological referral available. In summary, on the left side, you'll see the session content. What ended up being the intervention was 4 sessions, about 3 hours long, with groups of 10 to 12 people that address these topics. Processing stigma related to different identities, using cognitive behavioral therapy strategies, thinking about self-care, including HIV self-care, and then finally developing supportive networks and resiliency. We went about to pilot and evaluate this program with a randomized controlled trial. We had the opportunity to do that with about 250 participants, in addition to some qualitative data collection to supplement the RCT and understand more nuances of the program. So we talked with participants as well as staff, focus group discussions with facilitators and community health workers. In terms of what we were looking for the effects of the program, this was a pilot. So we were looking at feasibility, acceptability of the intervention in this context, really looking at different ways to measure stigma. So explicitly measuring internalized intersectional stigma, which we adapted for this setting by several different scales. We also looked explicitly at resiliency to try to balance that with stigma and some of the internalized stigma to understand more about our participants' resiliency and associations with resiliency, looking based on a scale that colleagues and I developed as part of the update of the People Living with HIV Stigma Index that many of you may be familiar with. It's a tool that is most widely used by the community of people living with HIV to measure experience of stigma amongst the community. We're also looking at depression, anxiety, and HIV service use. This is what the design looked like. So we had a randomized controlled trial with an immediate intervention group. So we had a pre-test, the intervention, a post-test, and 3 months later looking at effects over time to see what remained. We also had a delayed intervention group. So that means there was a pre-test, no intervention period, a post-test. So that was our control group. And then the intervention took place and a post-test there. So our main analysis is looking within this box where you're looking at the comparison between the immediate and the delayed group, but we're also looking at the effects for each group over time. Who were the 240 or so program participants? They, on average, were 26 years old. About 3/4 were men who had sex with men. Another quarter self-identified transgender women. About 1/3 were living with HIV, and it was very highly attended, with about 88% attending all 4 sessions. We also looked at these groups to check if they were similar, and we found that the 2 different groups, the immediate and delayed intervention group, were very similar to each other based on outcomes and various characteristics. Our participants reported quite high program satisfaction. It was for many people the first time that they'd participated in anything like this. And over 98% agreed or strongly agreed with this series of statements. So let me just share a couple of those statements. I felt comfortable participating in the workshop. I can use what I learned to deal with stress. The facilitators were supportive. I'm able to apply what I learned to my life, and overall satisfaction. Here we have a couple of qualitative quotes from program participants, where you see from the first participant, the teachers did a great job showing us how stigma can be fought, coping mechanisms, how you overcome fear, how you stand firm for your rights. I used to think so badly about myself as the second participant, but after the workshop, I was like, yes, I'm still a somebody. And a third person, the workshop opened my eyes to so many things. If I don't take care of myself, no one else will. I wanted to highlight some of the results related to PrEP uptake. We saw, so looking at health services, we saw on the left side at 3 months post-intervention that about 3/4 of the participants reported currently taking PrEP. So that is the immediate group at 3 months after the intervention, as compared to about half in the delayed group right after the intervention. So you can kind of see the increase over time we interpreted as we saw ever use of PrEP was quite similar at baseline. We also see here a qualitative quote. I must confess, before now I didn't take PrEP. I saw it like a punishment. But after this study, Now that we talk more about PrEP, I usually take it the way I'm supposed to. And also 2 of my friends who didn't take PrEP before started taking it because of the workshop. We also see significant improvement in psychosocial outcomes. So we talked about what those outcomes were earlier. Here we looked at internalized stigma specifically related to being a member of a sexual or gender minority. We also looked at internalized stigma related to HIV status, related to living with HIV. And then we also found a way to combine them where we're looking at intersectional internalized stigma together, as well as depression, anxiety, and sort of coping mechanisms. And you'll see that all of these outcomes improved. So internalized stigma was decreased related to both being a member of sexual and gender minority, both living with HIV and combined. The distinction here is that you see a significant change both on the part of the immediate group as well as the delayed group. So that struck us as what is going on with the delayed group that might lead to positive outcomes as well. And so we had the opportunity in our qualitative work to go back and explore that in more detail. And what we saw, turning to the next slide, what we saw, and I'm just checking my time, what we saw is that, so when asking why do we see improvements in both the immediate and delayed group, the delayed group participants reported to us that these issues they were talking about and thinking about for the first time ever in their lives. And from the first time they were contacted by people who were going to be collecting data from the baseline and starting to talk about these sensitive issues, it was an opportunity to share and think about it. And that they felt, this was a common theme, they felt that the questions themselves were an intervention, opening it up, and they had an opportunity to talk about it. So they developed rapport with the data collectors, both the baseline, then the follow-up, and then afterward with the end line. And so here's a quote saying, "Personally, it helped me because there's something that happens when you get to talk about your challenges even without solving them. Talking about it alone has a way of relieving you." A second theme that was less common but came up is the participants hearing about the workshops, and that from the group that had just gone through it before, and that it was really transformational for them. And so he told me about the teachings that had changed his life, and I was like, what is this about? And so they said that that also influenced, they started thinking about stigma, internalized stigma, coping, etc. And then lastly, the intervention happened to take place during Pride Month in Nigeria. And while Pride Month is not a very open in public celebration, a number of participants talked about it was an opportunity to reinforce their identities and be proud of who they were, and that participating in activities outside of the intervention as part of Pride Month also influenced what was going on between baseline and end line. So turning to the implications of this work, we found that this novel new work was feasible, acceptable, a promising approach, this affirmative group cognitive behavioral therapy approach in Nigeria, and that there were indications of positive outcomes such as reduced stigma, despite the randomized design not holding up. For next steps, we're thinking about what happens next, and that we, as I mentioned earlier, we intentionally designed this for potential impact at a larger scale, given that we have a group versus individual format that can reach more people and facilitation by community health workers. And so we find this to be a highly adaptable model for different populations, and we're thinking about how we might do that and test it in different contexts. And so for the last few minutes, I wanted to share what we are just getting started now, or what has just been approved to take place in the DC area. So underneath the umbrella of the DC CFAR, the Center for AIDS Research, we will be doing some similar work to adapt and test this program in the DC area. And as many of you know, some of whom are on this call now and participating as representatives from the organizations highlighted here. The mission is to promote and support research that contributes to ending the epidemic in DC and beyond in partnership with government and community. So we're going to be partnering with two well-known organizations, Us Helping Us and Whitman Walker, who huge clientele and working for many years in the context of Washington, D.C., as many of you know, to adapt and pilot this work. So let me try to get to my next slide. So this work, as I mentioned, will be to adapt and pilot the stigma reduction and mental health intervention for Black, sexual, and minority men in the DC area. And I'll be working with DeMark Hickson, based at Us Helping Us. Many of you know Us Helping Us is an organization that was founded by gay and bisexual Black, gay, and bisexual men to meet HIV and other needs. And so we will be working together to adapt and implement this work. The rationale being around a very high HIV incidence and burden amongst Black sexual minority men in the DC area. Stigma being a driver of the epidemic, as we discussed earlier. Resume, new share. I don't know if that happened. And so I'm trying to move my toolbar around so I can see that there are few evidence interventions that address these challenges. And then lastly, in the context of DC area, this positive framing of HIV wellness, and not just focusing on HIV, but also mental health and wellness more broadly, is very much in line with local priorities. We're going to have a phase 1 where we're adapting this in collaboration with the community using implementation science frameworks, and then pilot testing this HIV status neutral intervention. So very much for anyone, whether living with HIV or not, amongst the community, and testing it to see its effects. So I will stop there and say thank you very much again for including me in the conference.
Thanks very much, Julie. That was terrific. If you can quit your screen, that'd be great. Thank you. Yeah. So for our next presentation, we have two speakers, and maybe you guys can start to share your screen while I introduce you. That'd be good. The first speaker is Abdullah Badada, who is an associate professor of sociology in the School of Psychology, Sociology and Rural Studies, South Dakota State University. His research focuses on health and illness, stigma, gender, families, and parenting. He has published in several journals, including AIDS Care, Sex Roles, Child Psychiatry, and Human Development, and the Journal of Cross-Cultural Psychology. He serves on the editorial board of Family Relations. He is joined by Tyson Hallman, who is a psychology student at South Dakota State University. Guys, can you flip to the out of presenter mode again? Just choose display settings. Perfect. Okay. We'll take questions at the end. I see a couple of questions in the chat. So let's go to the second presentation, and then we can do some Q&A. Over to you.
Okay. We have like 15 minutes, right?
Yeah.
Okay, thank you.
You still need to get out of presenter mode. Sorry to keep saying it. Perfect.
Okay, thank you. Okay, it is, as you said, the study, it's ongoing, the study. We are not done with it, but we are presenting, the data we collected so far. And it's about, social support, HIV stigma, perceived stress, and satisfaction with life among people living with HIV in Oman. I am here with students of mine in the Department of Psychology. before we start, we would like to acknowledge, our colleagues who are collaborating with us from Oman and who are helping us with data collections and did some presentation also at other conferences.
Okay, so we're just gonna start off with showing you guys basically a global map of the areas infected with HIV and how many people are infected. And highlighted in red is the main area we focused on in our presentation and our research. But globally, fewer people acquired HIV in 2022 than any point since the late 1980s. And I thought that it was funny that my professor right here said that he doesn't think that much was done about it, but quarantining for COVID, and that's what stopped the spread. And this is more about the Middle East, North Africa, the area we focused on for this research. It has the lowest HIV prevalence in the world. But it did go up 61% in new infections since 2010. It has the lowest HIV treatment coverage globally and highest HIV prevalence amongst gay men and other men who have sex with men. And here's more information about Oman, the main country we focused on with our research. It's a country over in the Arabian Peninsula with roughly 4.5 million people living there, and expatriates make up 37.63% of the Omani population. But of that population, roughly about between 2,300 to 2,700 people are infected with HIV in Oman.
Okay. So in our study, what we have multiple measures, but we are focusing on some of them in this presentations. And in this presentation, we are focusing on subjective well-being, and mainly we focus on the cognitive component of subjective well-being, which is basically the satisfaction with life. The other one is the affective component, which basically look at the affects. But we are just doing this part of, subjective well-being in our studies. We have multiple measures, and this is our outcome measure, which is satisfaction with, life.
Yeah, so it's a 4-item scale made by Chung and Lucas. Basically, we just asked these people these 4 questions, and they were rated from a 7-point scale, starting from very strongly disagree to very strongly agree. And then next we have the HIV stigma scale, which is a 12-item scale, but as you can see, we only use 9 items from the scale. And they're separated into 3 different components of personalized stigma, concerns about public attitudes, and negative self-image. All these items were all rated on a 4-point scale from strongly agree to strongly disagree, being at 4. And then another scale we used was a multidimensional scale of perceived social support. This one's also a 12-item scale, but we used the support from a significant other, which came down to be 4 items, rated on a 7-point scale from strongly disagree to strongly agree, being at 7. Next is a perceived stress scale. This is a 10-item scale, and all items were used. This was used as a 5-point scale instead of the other scales we used that were more 7. And then 0, it starts at 0 being never and 4 being very often. And then as you can see at the bottom of this slide, it shows you the levels at which they scored and what it means for their perceived stress. So this is basically like some demographic of the information we gathered from our sample. There was 128 people tested positive for HIV for this sample. Of those people, between them, they were anywhere from 18 to 62 years old. As you can see, most of them were male, but there were still a small portion that were female. And out of the subjects, out of Any of them, they could have been living with HIV from anywhere from 4 years all the way to 30 years. Which 30 years is very impressive to me because it shows that we are slowly providing a solution. And then another thing is the people infected, you can see that the majority of them, almost at 90%, had high school or less for education. And a small amount of them, only about 10%, had college or higher. And then out of all of these people, almost 80% of them lived with a spouse, or HIV positive spouse, I should say.
Want to see this or do you want me to say? Okay, here are basically the 4 scales we used and the items, numbers which, Tyson just mentioned, and this is just the reliability levels for all the scale, which is very interesting, very kind of high, especially the received support from significant others. Okay, so here is just we focus on in this slide on the HIV stigma scale, and we just got the kind of percentage of participants who agree or strongly agree, and when they answer these items, as you can see, when we look at maybe we can just put an arbitrary cutoff points, which is about 50, almost all of them, except these 2, and you go to the highest one here, like 86, 85. Those are people who believe that most people think they are like, dirty. They think, people feel uncomfortable around them, etc., which is some of these like typical answer we see, unfortunately, in many, studies. Stress, if we're going to look at it again using, kind of way of categorizing perceived stress, these are not, clinical kind of markers or, cutoff scores, rather than just, based on normalizations. What we see here, the majority of the participant, if you're going to put both those who, received like, the level of stress as moderate or high, it's almost 90% of them have like experience stress. In general, could be related, to HIV, could be related to other issues, but in this context, maybe mostly related to their experience with, HIV.
Okay, so right here you can see that we have a graph of basically our hypothesis of what we think would happen with all this. And if you look at the far left, you can see that we hypothesize that social support from significant others would decrease perceived stress and HIV stigma. And then once we get to the middle there, you see that we also predicted that HIV stigma would increase perceived stress, and then perceived stress and HIV stigma would decrease satisfaction with life.
Okay, so what we did the structure equation modeling using the data we collected, and we run the model. It is, as you can see, and as predicted, as the, significant received support from significant other increases, the HIV level, decreases. The same thing as the levels of significant support received from significant other increases, the level of stress decreases, etc. We run, a path from significant others all the way to satisfaction with life was not significant. So these are the only paths significant that we found in our, studies. With this, we would like to thank you, and we just leave it if you have questions, and we're ready to answer your questions. Thank you.
Thanks very much to both of you. That was great. Thank you. Thank you. Are we able to run the video?
Hi, my name is Bella, and I've been living positive with HIV for the past 22 years. I share my story with family and friends to help the next person who does not know their status to go and get tested and start looking after their health, whether they're positive or negative. I share my story about why I wanted to know my status, and when I found out I was HIV positive, I also shared the emotions I went through, and how I got over it. Stigma is still very much out there. So if one is not ready to disclose to the whole world, they can find a buddy to talk to, someone who becomes an accountability partner, and also someone to talk to from time and time, as it is very important for one's mental health. Sharing my story has helped a lot of people to know their status, and I know there's a lot of people in my community and in my family who now know their status and have started looking after their health. Together, we can end stigma and discrimination.
My name is Oluwakemi Oguntimehin. I am a sickle cell advocate from Nigeria. Here are a few tips to help you share your diagnosis with friends or family. Create an appropriate time where you can have a private conversation. Do not disclose more than what you are comfortable with. You do not owe anybody your full medical history. Explain your diagnosis to them in a simple terms, like, I have been diagnosed with sickle cell disease. It is a genetic condition. Just like that. Share your treatment plans. Share how sickle cell might affect you, like having a sudden pain, dealing with fatigue, etc. Be open to answer all their questions. Ask for their support, and do not forget to remind them that you are still you, irrespective of your diagnosis. I hope these few tips helps you. Thank you.
Hello, my name is Samuel Lopez, and I am living with HIV, and I also have substance use issues and mental health issues. The diagnosis of HIV was devastating, and because of the stigma, I kept it very as a secret to myself. But I realized that other people had found a lot of comfort disclosing their status. When I did it with someone on my side, and I disclosed it to the world. And now I feel so good, because now it doesn't matter to me what you think. I feel good that I'm proud to be who I am, and after all, I can no longer pass it to you.
Thanks very much. That's very powerful, isn't it? Yeah. Wow. Wow. So there's some questions in the chat. Maybe I'll read them if that's okay. And the first one was for Dr. Polowitz. Thank you for presenting this valuable work. As intersectional stigma encompasses stigma related to multiple stigmatized social positions and characteristics, such as HIV status, gender, sexuality, economic status, race, ethnicity, occupation, etc. How did your team determine what to include in the experience of intersectional internalized stigma that the project measured and that the intervention targeted? It appears that the foci were intersectional HIV-related stigma and SGM-related stigmas, but please share if other forms of stigma were included. That's kind of a long question, Julie. I hope you can.
Thanks so much. Thank you, Amelia, for that really, insightful question. And thanks, Chris. So yes, intersecting stigmas have additional heft because we represent so many identities. There are stigmas related to many stigmatized identities that often come together to exacerbate the challenges we have with stigma. But you need to address simultaneously, or it's important to be aware of these various intersecting stigmas. In our case, we did choose to focus, as you say, on these two main areas as self-identified key areas based on what our communications with the community as to what they're talking about and what they're concerned about. So they did focus on HIV-related stigma and stigmas related to be a member of a sexual or gender minority. So that's the work in Nigeria. When we're thinking about transitioning to some similar intervention in the DC area, there are other intersecting stigmas that are particularly salient for the community here in Washington, D.C. And so in this case, we're starting out by focusing on HIV stigma, stigma related to being a member of a sexual minority, and racism, stigma related to race. So here we're going to be incorporating all three simultaneously with explicit messages and an opportunity to critical thinking and addressing the context of DC and the United States. So it's important to acknowledge that there will be some important adaptations, but that there are multiple different types of stigma, and you want to tap into what's most salient for the community that you're working with. Thanks for raising that.
Yeah, thanks. That's good. Just another quick question. Did you visit Nigeria during your research?
So the Population Council has an office based in Nigeria, and also we have Nigerian staff working in it. So the answer is yes, I did visit the office and worked with staff based in Nigeria. But often, and it's really the folks on the ground who have the best insights as to how to do implementation science and do work and develop the intervention. So I want to call out the staff that were involved with this project, who are sitting in Abuja, or sitting in Lagos, and our partners there as well. So I did visit, I did participate along the way with our staff who are based in country. Thank you.
So a question for Abdullah and Tyson. How has the cultural notion affected the acceptance of sexual health education amongst parents and young adults? Oh, you're on mute.
Yep. Well, Oman is a little bit open-minded when it's come to acceptance of, sexual minority comparing to other Arab countries, which is very interesting. Another one close enough is Lebanon, but historically Oman is, they tend to have an open mind about sexual activities, and especially men who have sex with men. So they don't, when you looked at the scale about the stigma, disclosure, when we ran it was not, influential in the kind of predictions of the satisfaction of life because they are open and talking about stigma, HIV, and sexual activities. But still, there is a stigma attached to HIV, regardless of the mode of infections, and comes from some kind of segment of the population. But they are open. I met with many HIV positive individuals in Oman. They're open about it. They are proud about it. They have no issues whatsoever. But I think the issues comes when they interact with some, or segment of the populations, and I think it to be a small even segment of the populations. Another thing, sometimes like unconsciously they internalize, stigma, and that's one thing that we need to work on. Julia's work is very fantastic, and I'm gonna talk to her later about that. Because mostly what we did is just gauging, attitude, perceptions, what have you. Of course, my colleagues in Oman are almost all of them physicians, so they are like interested in helping people living with HIV, but we are limited in terms of fund, whatever. But at least we try to publicize, their needs and the stigma they kind of experience from some people in Oman.
Thanks. Then there was a question for all of you. I wonder if either of the study's interventions plan to pilot the interventions specifically with African-born people living with HIV in the US. The DC area has a growing population of African-born or first-generation people living with HIV. Having a culturally sound intervention would go a long way in this area. Maybe, Abdallah, maybe you can go first?
I will go first, but most of my work is international. It's not, I did one long time ago study in North Dakota, but that's it. I mean, most of my work international. And again, what is missing, again, because of funding and because of some, restrictions, is we did not get even to the level of intervention. Mostly we do kind of, basic studies, trying to figure out, perception, attitude, internalize stigma, support, what have you, but we did not get to that, stage of intervention. And, there are multiple project ideas, but there is no fund, unfortunately, to do these, studies in Middle East mainly. I mean, there are some, mostly you go to Morocco, they have some studies there, mostly, funded by international organization, but the rest of the Middle East, Iran, of course, these two countries that they have a lot of research on HIV because have a lot of people living with HIV, but the rest is, as we saw, show on our slide, we have assumingly the number of people living with HIV in Oman is only 2,500. So for some, government, what have you, they just think, or funding agency is not a big deal. Let's just focus on other countries that, have a lot of people living with HIV. So unfortunately, these are main issues that we encounter when we go to the next stage, for intervention. So we just keep doing mostly basic research, and it's limited to some countries in Middle East. Thank you.
Thanks. Julie, do you have any thoughts on this question?
Thanks. So what I shared that's about to be taking place under the umbrella of the DC CFAR is the first study of trying to adapt and expand into the US. But I think other work with African-born people living with HIV or African-born populations would be a great additional population that could be a great link between what we learned in Nigeria, for example, and what we learn in the DC area. I think the main point, so thank you for raising it. So would love to do that kind of work and happy to collaborate for anyone who's interested in pursuing that. One of the underlying points that this makes me think of that I just wanted to put out there is, as being the co-chair of the Global Scientific Interest Group as part of the DC CFAR, our goal, and one of my goals, is to think about lessons that we could be learning across different settings. So I think that there are lessons that we can bring from the US, for example, to a setting like Africa, to various African based settings. But there's also lots of learnings we could take from our, in this case, African based work and bring it to the US. So I think there's really opportunities in both directions. And in particular, some of the community based work that I and my colleagues have been involved with can supplement a lot of the other types of work that are more facility based here in the US. So I do think that framing is really important, that there are learnings across the globe that can go in both directions. So thank you.
Thanks. Another question, maybe for anybody. What about stigma around substance use, Julie?
I think this takes us back to our intersectional stigma issue. So if I were to be doing a program with substance users, certainly you would think about stigma related to substance use. And the main underlying point for me is to explicitly address it. So if you are doing work with substance users, for example, you would explicitly both measure the stigma related to substance use and try to see that in the context of other key stigmas for the community, as well as intervene programmatically, directly around substance use issues, in addition to other key aspects of the community, in this case, perhaps HIV stigma. So important to do both.
What about substance use in the context of Oman? Abdullah and Tyson, do you have any thoughts on how that plays out in the context of Oman?
I think there is a high percentage of HIV infections moved in Oman because of substance, injections. Being close to, Iran, which is the high percentage of HIV infection in Iran because of, drug injections. Oman has the same issues because of that. So, but I haven't seen a study that looked at substance abuse, but as Julie said, there is, always this intersectionality that's very important to study, in conjunction with HIV stigma. But I haven't, and we did not do it, no.
Thanks. I think our time is finished now, and I don't see any more questions. So if it's okay, I'd just like to thank all the presenters, and thanks Sinelmo for making the video happen. And I thought the session was really, really good. So thanks everybody, and have a good rest of your day. Bye now.
Thanks very much.
I'm going to send you an email, Julia.
I would welcome.
Thank you. Bye-bye. Take care.